How many of you, when you were children, played doctor? Let me see a show of hands. How many of you played doctor when you were? Okay, excellent, thank you. How many of you are still playing doctor? Okay. Yeah, those are the naughty ones, I see you. Now, how many of you agree that a legislator that never went to medical school should be playing doctor? Say it again, louder. Can we get a chant? Hell no, hell no, hell no. All right. So, today, we are all going to play doctor, okay? Today's presentation is going to be called Let's Play Doctor. And today, rather than being, the typical what you hear all the time, how CBD1 receptor and CB2 receptor and AG and on and on and on, we're not going to talk about that today. Today, you are all in a medical conference, and I'm presenting a case to all of you. So all of you, put on your doctor hat on, because you are now doctors. For those of you that don't know me, I am a primary care physician in the state of Florida, have been an advocate for medicinal use of cannabis in the state of Florida, participated with United for Care campaign during 2014 and 16, have completed the mandatory 8-hour course recommending high CBD, low THC, but I primarily recommend high THC, so don't anybody freak out and start telling me, oh, you're a sellout. No, I do recommend the high THC. I've completed also the 2-hour medical cannabis course, and I've recommended low THC and medicinal cannabis to over 50. As of last night, I put in my 78th patient in the registry. And we got out of the office at 9 p.m. Hopefully today I'll put in 2 more. So here we go. Whoa, that's not me. There we go. Okay, so patient OR. I can't use names because of HIPAA violation. And you as doctors know about HIPAA. So a 39-year-old Hispanic female who is 5 feet tall, weighed 152 pounds, has a body mass index of 30, okay? She presented on November 10th, 2016 for an initial visit to become established with a new primary care physician, me. The purpose of her visit, she needs medications and needs referrals to different multi-specialties. Typical patient, right? Okay. She had just moved down to the area. She's originally from the Northeast, New York, Connecticut area, and needed a doctor. So these were her conditions: mixed connective tissue disease, pulmonary hypertension, pulmonary effusion, atelectasis, fibromyalgia, major depressive disorder, general anxiety disorder, gastroesophageal reflux disease, aka GERD, and obesity. Now, doctors, we're going to review, because I know a lot of you may have forgotten what a lot of these diseases are. So we're going to review these diseases for you guys, okay? So don't anybody freak out. So, mixed connective tissue disease, also known as Sharp syndrome. It is an autoimmune disease. Autoimmune means that the body's defense system attacks itself, so it sees its own body as its enemy, okay? Combines features of the following autoimmune conditions: scleroderma, myositis, polymyositis, systemic lupus erythematosus, or lupus, SLE, rheumatoid arthritis, as well as dermatomyositis, Raynaud syndrome, and sclerodactyly. As you can see, it is called an overlap syndrome because it encompasses all of those conditions. Now, understanding that it's been a while since you guys did a residency, so I'm going to go ahead and review what each one of these autoimmune conditions are. Scleroderma, a long-term autoimmune disease that results in hardening of the skin. And I put a picture there for you to remind you guys what it actually looks like. Because the skin becomes so thick, it pulls back, and so there's actually no facial expression from this person, okay? It not only affects the skin, but can also affect the internal organs. The underlying mechanism involves the body's immune system attacking healthy tissues. So we've got one autoimmune, right? Okay. Myositis, polymyositis. Anytime you see itis, you remember that it means infection or inflammation. So a general term of inflammation or swelling of the muscles. Myo means muscle, poly means many. So polymyo means many muscles that are inflamed. Lupus, also known SLE or lupus, another autoimmune condition which the body's immune system, again, attacks itself. Common symptoms include swollen joints, fever, chest pain, hair loss, mouth ulcers, swollen lymph nodes, feeling tired, and a red rash commonly seen on the face. This is typical and pathognomonic for someone that has lupus. Now, you guys getting the picture of this patient that came into my office, right? You're getting an understanding of what this woman is kind of looking like, right? Okay. Rheumatoid arthritis. Rheumatoid arthritis, another long-term autoimmune condition that typically results in warm, swollen, and painful joints, pain, stiffness worsening after rest. So they wake up in the morning and they can't move. They're stiff, they're tight. Also, one very classic presentation that you remember from your training is that it happens bilaterally. So whatever happens to one side of the body happens also to the opposite side of the body. And the deformity occurs symmetrically, which is very cool, and that's the differential to differentiate it from regular arthritis, okay? The disease also affects other parts of the body, causes low red blood cell count, inflammation around the lungs and the heart, okay? Whoops, sorry about that. Okay, dermatomyositis, another myositis, but this one also affects the skin. So now she's got inflammation of the skin and the muscles, okay? A rare connective tissue disease related to polymyositis, characterized by inflammation of the muscles as well as the skin. Derma means skin, myo muscle, itis inflammation, okay? It also affects the esophagus, so now you understand that she's having a hard time swallowing. The lungs, she's going to have a hard time breathing, and the heart, which means that the heart's going to have a challenging time beating, okay? Raynaud syndrome. Raynaud syndrome is a condition that affects, it's a spasm of the arteries of specifically the hands, sometimes the feet, rarely the extremities like the nose or the ears. It's very patriotic. Why is it very patriotic? Because they first turn white, then from white they become blue, and then from blue, once the blood returns, they become red and hot. And when it becomes red and hot, it burns like hell, okay? And there's no ability to use, because anything that they touch, anything that gets near their hands, will cause that burning sensation. It can last from a few minutes to a few hours, okay? Now, again, you're getting the picture of what this person is, right? What this person looks like, okay? Sclerodactyly is a localized thickening and tightness of the skin of the fingers and toes. Sclerodactyly often leads to ulcers, so they end up with skin ulcers on their hands. They have to keep their hands moist, otherwise, because as the skin expands, it cracks, and when it cracks, it becomes dry and it can get infected, so they have to have constant topical antibiotics to use on their hands. Pulmonary hypertension. We just finished all the autoimmune conditions. Now we're going to talk about all the other conditions that this patient presented with. Pulmonary hypertension is an increased pressure in the arteries that take blood from the heart to the lung and from the lung back to the heart. And the person presents with shortness of breath, difficulty breathing, and you see the inhaler because they can't live without an inhaler. They have to constantly have that inhaler in hand, otherwise they can't breathe. Pulmonary effusion. This is an excess accumulation of fluid in the pleural cavity, which is the fluid or the space around the lungs. And on X-ray, it looks like this, okay? Notice that this is a fairly normal lung. This one here is all fluid, okay? Together with that, she had what's called atelectasis. Atelectasis is a collapsed lung, okay? The whole lung collapsed. And the way to remember this is atelectasis sucks. This is the windpipe or the trachea. Notice that it's moved to the side where the atelectasis is. It means that it sucks it to that side. So atelectasis sucks. Remember that. It's a board question, okay? Fibromyalgia. Let me see a show of hand of all those in this audience that have fibromyalgia. Okay, that only you? Okay, as you all know, fibromyalgia is a conglomeration of symptoms. Generalized body aches, pains, always in pain, everything hurts, okay? It used to be the garbage disease. When you went to the doctor, when patients used to come to you guys and you guys couldn't fit them into any diagnosis, you would say, oh, you got fibromyalgia, it's all in your head. It doesn't exist, move on. Okay, now, would she be depressed? Absolutely. Would she be depressed? Duh. Absolutely she's depressed. But look at how depression is defined. They have to have all the mental disorder characterized by at least 2 weeks of low mood. How many years do you think this person has lived with all of these autoimmune conditions in all of these situations? Okay? So yeah, she's got the right to be depressed. And would she be anxious? No shit, Sherlock. I mean, of course she's going to be anxious. She's going to have anxiety, and with anxiety comes irritability, twitching. Now, who would want to be married to this person? She is married, and her partner was with her every time. And he was more aggressive about her treatment and her care than actually she was. Okay? She had gastroesophageal reflux, GERD, which is, as many of you have experienced, I experienced it last night because I didn't take my medicine in the morning. Idiot me. So it's a burning sensation. You feel this burning coming up into the back of your throat, and you got this metal taste in your mouth, and it's pretty disgusting. But it also gives you a sense like you're having a heart attack because it causes chest pain. Okay? And because her body mass index was 30, she's considered to be obese. Okay? So now, everybody in this audience has a very clear picture of what this person looks like, right? Now, I'm going to ask you a question. Do you think that this patient and I established a relationship on this visit? Does anyone think that we did not establish a relationship on this visit? Based on all this information and everything that I've gathered, did she and I have a doctor-patient relationship established? Yes? Anybody say no? Why do you say no?
I don't know. Too much for a new doctor for her to trust.
So you don't think that we've established a relationship just because there's too many diagnoses for me to have worked with her? Is that what you're saying?
That she had been to so many doctors that she didn't trust another doctor until he could prove something to her.
Okay, well, there's really nothing for me to prove. It was just a matter of listening to what she had to say. Wouldn't you agree? Okay. All right, so after going through all of her conditions, these are all the medications that she's on. All right? And we'll go through them very quickly, of course. Humira, we all know that's for her autoimmune conditions. Vitamin B6 to replenish the blood cells and help the blood cells so she doesn't go into severe anemia. ProAir, that's the inhaler that she can't live or walk without. Cymbalta, Neurontin, and Roboxin, those are all for the fibromyalgia. Hydrocodone, acetaminophen, which is Lortab, Norco, for the pain. Linzess is for the constipation caused by the Lortab. Diclofenac gel, topical gel, anti-inflammatory for pain. Depakote and Abilify for the depression. Trazodone to help her sleep. Xanax, duh. Xanax for anxiety. Protonix for the acid reflux. And phentermine because, I mean, come on. She is obese. She needs to lose some weight, right? All right. So what did I do on that day? On that day, we refilled her medications, ordered a baseline blood work, prescribed the water pill and potassium because of all the fluid that was in her lungs and the swelling in her legs. Make sense? Okay. Then I referred her to the rheumatologist for the autoimmune conditions, dermatologist for the dermatomyositis and the cracking of her skin, the pulmonologist, the lung doctor, because of the fluid that she had in the lungs and the collapsed lung that she had. cardiologist because of the pressure that's flowing back into her heart, pain management doctor to address her pain, psychiatrist for the anxiety and depression, gastroenterologist for the reflux, and a nutritionist to help her with her diet. Pretty complete, yes? All right. So, second visit. She comes back on December 6, 2016 for a follow-up visit. What did we do? We reviewed her lab work. Remarkably, the labs were pretty good. Not too many issues going on with her labs. We found out what her consultant, what the referral doctor said and did, and she was scheduled with the lung doctor to put tubes in her chest to extract some of the fluid because the medication that I had given her was not enough to get the fluids out. So she had to be scheduled to have bilateral chest tubes, okay? And then I did medication refills for her phentermine, her hydrocodone, and her alprazolam because in the state of Florida, you can only prescribe a controlled substance for 30 days. So every 30 days, the patient has to come back to get refills on these controlled substances, okay? Similar to the therapeutic cannabis that they have to come in and see me every 45 days, right? Okay. And continue with the referrals, and between her first visit and this visit, she saw me on TV. And I was interviewed because the Amendment 2 had just passed on the 8th. I saw her on the 10th. So between the 10th and the 6th, she saw me on TV and wanted to have a conversation about getting her started on medical cannabis, which, is she a candidate? Yes or no? Yes. Thank you. Even though those diagnoses are not on the 10 approved diagnoses under Amendment 2. You got it. Third visit. Patient presents on January 6th for follow-up visit to report on consultations with the specialist, obtain her final medication refills for the phentermine, the hydrocodone. Why final? Because in the state of Florida, a primary care physician can only prescribe a controlled substance, like for pain, for 3 months. Beyond 3 months, I have to refer her to pain management because I cannot control chronic pain for more than 3 months, unless it's cancer-related, okay, for those of you that are from out of the state. And I increased the Lortab to 4 times a day, refilled her Xanax, addressed continued pending referrals, discussed the recommendation of medical cannabis on her next visit, because on her next visit, she would have been my patient for the 90 days, right? So we're all on board, we're all on the same page. She's lined up, she got all her referrals, she got all her medications, and in 30 days, or on the 90th day, she's gonna get her recommendation, right? Everybody's on board, she does meet the qualifications to get it, right? All right. So on January 10th, Tuesday morning, I'm in my office seeing patients, and I get a phone call, and my medical assistant comes in and tells me, "Doctor, there's an emergency phone call from the hospital, and you have to take it." I'm like, "What?" It's like, "You got to take this call. It's a patient. It's the ER doctor." I'm like, "All right." So I excuse myself from the room, go into the front desk, go to my office, grab the phone, and I say, "Dr. Rosado, may I help you?" So I say, "Yeah, doc, this is Dr. X. This is Dr. X from the DeLand, Florida Hospital Emergency Department, and it's regarding your patient OR." And I'm like, "Oh, yeah, I just saw her on Friday. What's wrong with her? What's going on?" I say, "Well, hang on, I got somebody here that wants to talk to you." I figured, okay, it's probably her husband wants to talk to me. Phone passes over, says, "Hello, Dr. Rosado?" I'm like, "Yeah." It's like, "Hello, this is Officer X with the Volusia County Sheriff's Office." Next words out of my mouth were, "Oh, shit." What happened? Why are you calling me at my office at 9:30 a.m. about this patient? And they said, "OR passed away this morning." I'm like, "What? She's 39 years old. I mean, yes, she's sick, but what happened?" It's like, her and her husband went to bed last night, and he woke up this morning, and she was unresponsive. When he turned over to look at her, she had pink sputum around her mouth, which is typical of a patient that has pulmonary effusion because they spit up pink, frothy spit. And he said he woke up, saw her laying next to him. She was unresponsive, and dialed 911. When EMS arrived on the scene, she had already been dead. They transported her to the emergency department. We pronounced her here. So next question I ask is, are you guys going to do an autopsy? And the response was, no, unless you sign the death certificate, no autopsy is required. Are you willing to sign the death certificate? Absolutely, she's my patient. So they faxed over the death certificate, I signed it, filled it out, and signed it. She didn't make the 90-day waiting period to get her medical cannabis. 1 month away from getting her medical marijuana card, I was signing her death certificate. You hear me every time that I have an opportunity to have a microphone in my face, debunk and fight about the 90 days. Whenever you guys speak to your legislators, your representatives, remember patient OR and the fact that she didn't make the 90 days. If you have any questions after the presentation, I'll be in the back of the room. You can come and grab me, or you can speak to my medical assistant, Wanda. Wanda, please stand up. Thank you. If you have any questions or how to get a hold of me, there she is. That's my personal email address, and that's my office number. If anybody wants to talk to me personally, one-on-one, there I am. You can get a hold of me. Thank you very much for your time. Thank you, doctors. You were amazing.